So welcome everybody. Yes, welcome to 2025. My heart goes out to everybody struggling in Cali right now, and I'm actually on my way out there tomorrow, I think. And yeah, I prayers for everybody, and I hope you're all doing as best you can in this really tough time. So thank you for tuning in, our first webinar of 2025. Jim picked a topic that we kind of visited before a little bit. So you notice I always blame Jim for the good and the bad, but this is always good. Um, but I think this is such an interesting topic that I didn't kind of mind delving into it a little bit more. So I kind of went back and looked what I've done with it over the past year or two, and we touched on it. And I think there's so much to talk about when we talk about the incisal edge position. So in the past, I had really talked more about looking at that edge and trying to understand not only the form, the phonetics, its functional capabilities, and the aesthetic parameters, but really how it really works intraoral for each patient. And I would love to tell you that, oh, every incisal edge, I use EE9 or blue water, or I use the same translucent blue, and I use two mamelon materials. But boy, that's so not the case. And that's why it makes it so difficult for me to kind of talk about such a specific area, because it's really very pertinent to the patient and what I'm looking to achieve for that particular patient. So in the past, the way we kind of worked through it was first functionally. For me, when I look at an incisal edge, before I'm thinking about aesthetics, I'm always thinking about the functionality of the position of the incisal edge. And I want to make sure that whatever we're doing restoratively is going to stay there restoratively. So for all of us, I think we have to be much more cognizant of this, in the sense that doctor sends us a case, they ask for 4, 6, 8 veneers, we make the veneers, and then 6 months later something breaks and it's kind of back on us. Why? What material did you use? Was it strong enough? Now I need a harder material. And those things kind of really rub me the wrong way, because the truth of it is what we're really looking to achieve is, where does the incisal edge belong? And more importantly, what is the functional capability of it? So when we look at it, as much as I want to make them pretty in different ways, meaning different translucencies, different effects, different opacities, I really want to make sure the functionality of it is correct first. So I look at envelope. For those of you who aren't familiar with envelope, just a quick recap on what we've talked about before in some of the incisal edge webinars. I want to make sure that that lower incisal edge functions in a way where it's not going to catch or chip on my upper incisal edge. Now, I'll say for the people closer to my age today, I think most of us learned the occlusal concept, and we learned about anterior coupling, where we wanted the posterior teeth to touch and the anterior teeth to lightly touch. And as we moved, everything kind of coupled and guided together. That has changed over the years, and that is not the way we do that anymore. For me, it's kind of the opposite. I don't want my anterior teeth touching, especially the front four. What I'm really looking to do is create space and room in there, so I make sure that I could pull maybe 15, 20 microns through there for many reasons. And that's really not just to create a constricted envelope, but my lower teeth are hitting on my restorative uppers, or even the natural uppers for that matter. Yes, I still work anterior guidance, a topic for a different day, although I have different concept on that too. But that's all I care about at this moment, as I'm developing where the incisal edge, what it's going to look like. Excuse me. What I'm really worrying more about is, what is the lower envelope that's not going to interfere with my incisal edge position. So that's what we call pulse-out envelope of function. And that changes from bite to bite, class 1, class 2, and class 3. I'm sorry, my voice sounds so rough today. I'm sure coffee will help that. So as I look at those different positions, I just want to make sure that I'm understanding of where my lower incisal edge will meet. And the further up that it's going to meet on the incisal edge, the more concerned I have to be about the restorative option that I use for it. Okay, so that's the functional aspect of it. Aesthetically, what's the proper incisal edge position for the patient that I'm working on? So obviously the length of the incisal edge is something that we always talk about. Simplicity, where does it belong in the face? I think for those of you who saw me in Chicago last year, I did a whole piece on this, just talking about where does the incisal edge belong in the face? And every case that I work on, I'm treating it like I'm setting a denture case. I'm pretending there's no teeth in the mouth, and then I'm taking what I see in the face and deciding where the incisal edge goes. From that point, I have to make sure that it's the proper position for the face, and then I'll come back and check the functional position later on. But each time I'm doing it, I want to make sure that I'm also not only putting it in the right position, but I'm using the right effect for the incisal edge, because there's a difference between a 60-year-old patient to a 25-year-old patient. So once I understand where it belongs in the face, then the next part of it is going to be, now I have my incisal edge position, IEP as we call it. And then I'm going to look at the face and say, okay, I'd like to make this particular case maybe 2 millimeters longer. So I'm going to kind of make that evaluation based on the face, and I'm going to try to make sure that it's where I want it to be in the appropriate area of the face. So you can see here, like in this photo, that it's got to be a little bit more in that area. You guys can see that okay? Just want to make sure. I'm trying to get my clicker here to work. It's not working well. Hold on one second. Let's see. Okay. So, sorry, my clicker wasn't working there. So, obviously, everything we do for the incisal edge is about looking at nature. How much translucency? What are the mamelons? Is there secondary dentin formation? Is it a youthful tooth or an older tooth? And those are kind of the concepts that we addressed more in the earlier videos, earlier webinars, but I'll touch on it again. So what I really want to make sure is that we understand that there is no such thing. It's kind of like the snowflake concept, right? There's no incisal edge that I look at and say, okay, this one's exactly like that one. That one's exactly like that one. That one, not at all. Look at the differentials that you see here. Look at these salmony, nice mamelons that float in this translucency here, as compared to here where I almost don't see the mamelons. I just see these little peaks in there, but I kind of have more of a general translucency, whereas here I don't really see any mamelons. I see a lot of translucency and a lot of secondary effects happening, but I don't really see the finger mamelons that we talk about. In a case like this, I kind of see 0 mamelons, but yet I have translucency. Here again, not much in the mamelon world, but more translucency and more effect. And then here you kind of have the mamelon look, right? So point of it is you can't just have a standard formulation for every time we're trying to create an incisal edge. It really has to be pertinent to the patient that you're working on. And each time I do it, I'm really trying to think through what are the effects that I need to achieve where I'm going in this area. And realistically, I have to be somewhat conformative to what I'm doing in smaller cases. So if I'm doing a single central, if I'm doing 2 units for that matter, or even 4, I'm really working conformatively. I'm really working to match what I see in the teeth already. The only time I have free range is when I'm doing larger cases, 6, 8, 10, full mouth, full upper arch. Then I have the ability to come back and say, I can create anything I want. But if my goal here is to match that tooth, I have to match it. I can't just create mamelons because I wanted to. And like I said, do you really see mamelons in this tooth? No. So my buildup had to shift a tiny bit in order for me to accommodate what I see in the photo next to it. And it was a single implant central, by the way. That was an old one from a bunch of years ago. When I'm working more with these kinds of cases, which are a little bit more involved, then I'll start from the basics. What do I mean? Well, do we like her current incisal edge position? If we do, great. And you can see her smile looks a little controlled here. It almost looks like she's not really smiling in her face photo, but yet when she gives you a big smile, as you can see, she's kind of a VME patient. She's showing a lot of pink there. So I do everything the exact same way. And by the way, just look at her enamel. Let me blow that up for you guys. Look at the enamel that you see there. Is this the kind of an effect that you'd want to create for a certain case? Maybe. I get it. It looks a little ambery and there's that secondary dentin formation. At the same time, if I'm making a single central for this patient, I got to follow that. If I'm doing all the teeth, then I can improve on it, but I have to realize how much improvement, what that means for her and her final result. So we did everything that we would normally do. We developed a diagnostic wax up. We figured out where the incisal edge was. This became an implant case. and it was designed very well by a friend of mine, Dr. Dane in Ohio. And what he did was he actually had all the implants placed where we could section this out into three-unit bridges. I know the all-on concept is so popular today, and in some cases, I get why we're doing them. In other cases, when we could stick to crown and bridge, we should. Some of you might be thinking, why did I use metal ceramics for this? For me, when it goes to implants and connector sizes, I still think metal ceramic is a much better way to go across the board. It doesn't mean I use them for every case, but on certain implant cases, I say a percentage of 40–50% of my implant cases that are kind of involved like this, I'm still going back to metal ceramics because I feel like I can get the best strength, the best functionality with the flexibility of the metal, the best aesthetics, and have the most amount of space to work in and have the most amount of support for the implant itself. Meaning if you look at the linguals here, I have some slides on this, but I didn't put them in. Pretend this was a tie abutment that I made here. Well, look what's left of my tie abutment, just that facial aspect of it. And that's now what my zirconia is getting cemented to. So I don't love that. I don't really feel like that's the most comfortable for me. So a basic dentin buildup here, and you can see in my dentin buildup, I'm already starting to create what I want my incisal edge to be. You'll notice that my incisal edge at this point is kind of straight across. I'm not really making a lot of up and down. Why? Because the end result for me with this case is not going to be a ton of translucency or a ton of mamelon and translucency next to it. It's going to be a little bit more of a monochromatic incisal edge for this patient. So I'll start in by using my translucent materials. In this case, this was VM13, so a little EE9 and EE10 mixed. I'm going to start using my mamelons here across that material, and I might come back sometimes with either an effect chroma that I might want to use for a mamelon or a chroma plus, or even an opal material on the interproximal areas. That's really dependent on how much translucent I want. In this case, I just stuck straight to the EE9 and the EE10 and some mamelons in between. And then the powder that you see here is just an EE1, a little bit of a whiter, brighter powder that I'll feather up to kind of transition between where my base dentin is and where my enamel effects are going to go. And I fired that. I wouldn't normally fire it, but I did just to kind of give you an example of what happens with the effect. So I'm creating some translucency, but notice how my mamelons are kind of clogging up everything else. I'm not having tons of translucency in there because I'm not really looking for that super translucent, very youthful looking tooth. I want kind of a little older tooth, although she does want a little brighter, whiter tooth. So look at what my mamelons did and how well they masked a lot of my translucency. And that's the effect that I use with either mamelons, effect chromas, and if I'm in Lumix, it might be a flow dentin or a mamelon material. It really depends on the system that I'm working in for it. But the goal of it is to decide how much translucency am I trying to create in that specific case for that specific person. Once I've done that, the next concept, and I've touched on this in some of the layering webinars, is how much filtration do I want to apply over that? So I know most of us, when we talk about enamels, we talk about how bright they are or how translucent they are. I kind of think of them more as filtration systems. The brighter enamel you use, ENL, something with a little bit more whiteness to it, the more it filters the light from passing through it. The more translucent you use, END, or even in the other families of enamels like NTs where they're more translucent, or windows, more light passes through, so it drops value. But from a value perspective, I think we all kind of get that. Where the challenge is how much light is going to pass through the enamel and see the effects that are behind it. So remember, look at the effects that are behind this right now. I only have very little amount of translucency towards the incisal edge, but you see how with my mamelon materials, I see translucency, but not as much, right? I'm masking it. Now the goal is how much of that do I want to mask with my enamel? And in this case, I want to mask some of it. I wasn't really looking to create this heavy translucency layer. So here we are with our final enamel on top, and you can see that I've allowed some of the light to kind of come through, but not all of it. I didn't want it to be a super translucent kind of a restoration. So there's our final implant case. These were all 3-unit bridges. It was first molar to first bi, cuspid to central, central to cuspid, and then first bi to first molar again. So really nice way to break up these, what everybody considered all on cases, right? Obviously you needed more implants for this. We have to have 8 implants instead of 4 or 6, 2 more implants, but it really is a nice way to manage through the cases, I think, for me. There's the final restoration. You can see surface topography, some little wear and chipping on the cuspid, so it looks a little bit more real. And this is on the pink tissue model. And then we'll bring this to the mouth. Also, as the doctor places this is on insertion day actually, so I'm hoping we got a little more papilla today. I didn't get any new photos recently. This was just inserted a few weeks ago. And the doctor will come back and just put some Teflon tape inside the holes and then composite those off. And what that means is we now have access to everything. For those of you who are saying, why not just put 4 or 6 implants, do it all on 4 in here? Well, for me, retrievability. If you do it all on and it's zirconia, if something goes wrong and something breaks, you're remaking the entire case. In my case, the patient bought 2 more implants, but we have access to 3-unit bridge for the rest of her life, which is kind of nice. So if anything ever goes wrong, we take a 3-unit bridge out, comes back, we can repair it, redo the porcelain. And by the way, I'm not doing a whole new arch. And just to throw this out there, it's a little off topic, but it gets frustrating because I hear so much about everything's zirconia all on, everything's zirconia all on. That sounds great up front to me, and I do a lot of them, so I don't want to make it like I don't do them. But the concern for me is when something goes wrong, who's eating that, and how are you managing that time? We all know those pucks are $200-300. They're 6-8 hours of milling time. The burrs break, something goes wrong. It's 40-50 minutes each time I fire that, right? That's a long process case to get to the end. And then if something goes wrong, all that has to start over again. So I definitely transitioned a little bit more to using Toronto type bridges with denture setups if I can. Doesn't mean I don't do all zirconia. I do, but I try to pick and choose the right case for the right patient. But if I really have an option, I'd rather have the extra 2 implants and break this up, whether it's 4 zirconia bridges or 4 metal ceramic bridges. I have options to come back and revisit the case as often as I want. And that's really the way I like it to be in the end. So you can see with her big smile, we didn't do pink on her. We tried to utilize and keep the pink that she had. And there's her final result. And it worked out okay. I'm looking for the finals. This was day of insertion. So hopefully I'll get some new photos from Dr. Dane. I forgot to put your name on there, Dane. Thank you for the photos for this. Dane took some nice pics on this case. When it's a little more complicated, like this particular case, I've mentioned in previous webinars that I don't want to do these smaller cases on digital models. You'll also notice that other larger case wasn't a digital model either. So not only am I slightly anti with the full arch zirconia restorations, I'm slightly anti some of these cases on strictly digital models. Digital is fabulous. Everybody knows I have 3 printers here and we're printing all day long. And we do work a lot on printed models for a lot of the cases. But I've said in previous webinars, and I'll say it again, we don't accept veneer cases on printed models, and some full arch implant cases we're pretty skeptical on. So we try to avoid some of those things for some of the printed casts, only because of the inaccuracies in the print and the details that we lose for that. And single centrals was the third that I left out. So why would I not take it on a single central? Well, look at the tooth. Again, I touched on this before. But if I'm really looking to nail this incisal edge, it's not only going to be about the translucencies and the effect and that little white frosting, it's also going to be about this topography on that surface. And I'm not getting that in the digital cast. I'm not going to get that in a digital cast for quite a while. So for me, those are kind of a non-option at this moment. I'm going to stick to a physical cast for that or physical impression for that because the topography is going to matter to me. When I start to evaluate through the tooth cuddle itself, I want you to notice the change that really happens here. So today our focus is really in this area, but I can't kind of ignore the rest, right? I have to look at this pinkish hue of chroma that I see at the cervical and how that value pops up in this middle third of the tooth. And then where does my translucency start? Because that's really the biggest challenge that I think most of us face when I'm in laboratories and I'm looking at the work that's being produced. Where we lose some of the aesthetics is in two major areas. One is the embrasure spaces that we're not creating like nature has provided for us. And two, in the amount of translucency. Translucency is not the last millimeter of the incisal edge. Sometimes, I mean, if you look at the distal translucency here, it's almost halfway up the tooth that I really need to be working that translucency in and bringing that translucency all the way up. Look at how translucent I am right here in the center of the tooth, right? It's not just that incisal edge position. So what tends to make our restorations look so much faker is that we tend to think our incisal edge is that last millimeter, millimeter and a half, and it's not. It's really from that middle third all the way up to the incisal edge of the tooth that we have to work a little harder in to really match that area. And I have to really think through the process of how am I going to get to each of those positions or those color ratios that I'm trying to incorporate in my restorative option. So in cases like this, where it's an implant single central, texture is going to be key here, getting that cervical chroma and then transitioning from that little bit of value into this translucent area. To do that, I'm going to do exactly what I would normally do in all my buildups. The only thing I might work a little bit harder, and that's a canvas buildup, by the way. The only thing I might work a little bit harder on is which effects are going to give me what I need. Can I just go straight with chroma effects, meaning that a mamelon material or an effect chroma or a fluorescent dentin material? Can I use mamelon materials? Will the mamelon materials give me the colors and the effects I need? Or do I want something different there? Sometimes I find that I'm actually mixing in. Maybe I want a fluorescent dentin and I'm going to mix in a little dot of a salmony kind of a stain, or I'm going to use a colored mamelon material and mix in a little dot of a white stain. Because what I'm really trying to figure out is what's going to work best to replicate what I'm seeing in that one tooth. Again, I wish I could tell you this such a simple formula. The simple formula that I'll touch on is my canvas. After that is the free world of figuring out what you need to get there and how you're going to accomplish that effect. And sometimes I need more than one. I need 3, 4 different little dots of ceramic that are going to help me to achieve that similar effect in the restorative option to make it look similar to what I'm seeing in nature. So in this particular case, you can see I think I achieved it. Maybe I have a little too much translucency, although I think in real life this shows a little more translucency, and it kind of worked out in the final as we're putting this in. So single central implant, and I think you can see here now in this photo, you see a little bit more of the translucency starting to come through there. You know, my finger with that blue glove is behind it, right? But that's the idea. What is the consistent part is the canvas. I'm creating the canvas the same way, and my canvas is either some opacious dentin material or the coping itself is providing that for me. I build my dentin. From my dentin, I start to transition into translucency. Notice where the translucency on this case is. It's almost halfway through the tooth on that distal corner. I probably even could have came down a little bit more on the mesial corner, right? So hindsight is always better for us, but looking at that now, my brain just went to, oh, you should have brought that down a little bit more. And even here, I would argue that I probably could have came down a little bit more with my effect translucency to get a better transition. This is not a real case, I don't think. This might have been the, this is a course model case, actually. This is a course, and for Jim and for you guys out there, I'm doing a course in Toronto, I think at the end of this month, on zirconia and ambria materials with Zoom-X porcelain. So I think it's a 1-day course in Toronto. Hopefully you guys will join us. And I'm going to kind of use this model. I think this is the one I'm using, if I'm not mistaken. But notice as I started to go through more of my enamels and my mamelons, I kind of did, right? I kind of scared myself when I looked at it here because I thought, oh boy, I didn't put enough translucency on there. But I did. Now look at the second part of this as I'm adding more translucency. Notice that I've come down almost halfway through the tooth, and that allows me to really create that canvas. Now that I have my canvas, now it's all going to be about the effects. What mamelon materials, what effects materials do I need? Do I want opacity? Do I want translucency? Do I want fluorescence? And those are all the things that you have to be able to think through. That's where I can't give you a simple formula all the time. I'm using 3 or 4 different powders, and sometimes I'm mixing them to work through those effects. But we will cover that a lot in the Toronto course for those of you who are there with us. Okay, so let's kind of put this together. So most of you know that in order for me to establish an incisal edge position, it starts with the face. I want to look at the face, I want to look at where the white belongs, and then what the health of the pink is. That's a standard formulation for me when I'm working through a case. And as I'm evaluating her teeth, and I think you guys should be doing the same, I hope you're looking at it and saying, well, which one do I like? Because before I start doing anything diagnostically, am I happier with the length of that 1-1 or the 1-2? I'm sorry, the 1-1 or the 2-1, or am I happier 8 or 9? Which one do I like better? And I kind of want to work through that concept first of figuring out which one I want to use. I know I want to close the spaces, and when I close the spaces, I'm going to create more width. Creating more width makes me think I want to keep more length, because obviously I don't want to keep this and then widen the teeth too much and have a square looking tooth. So I think I'm going to keep more of that 2-1 length there, or the number 9 length. So I'll do my diagnostic wax up like we normally would. We just did a modified wax up on the cuspid, or an additive wax up for a window veneer. We'll make our standard tray for that, and we'll deliver that wax up to the patient. And we'll evaluate, did I get my incisal edge position right? I think it looks pretty good in her face, actually. I like it. Maybe I'm a little too square on my design here, but I can modify that a little bit more as we go on. But look at the difference in the face, right? I mean, look what an incisal edge does to the face. And that's kind of the key point here is she looks like she's, maybe a teenager here. She's actually in her mid-20s. The face looks a lot younger, which is good in some ways, but she didn't feel good with it. And then look how that little bit of change kind of really changes and accentuates how the face looks. So that one little ability to put the incisal edge in the right position is so critical for us. After that, the doctor is going to use an APT technique, which really just means that he's going to use our wax up in the mouth. We did this additively, and he's basically going to prep right through the additive wax up. So take off 1.5 millimeters to 2 millimeters of incisal edge if needed, and then start prepping for the reduction, depending on whether it's going to be veneer or full coverage restoration. So this will be an APT technique. It'll be the same premise for us all the way down. Once we've done this, I want to make sure that he's provided the right amount of information for us, especially if we're going to stay in the veneer world. I have to understand, or our clinical partners have to understand, that I don't want them wrapping this veneer over to the lingual. I want them to give me more of a rounded finish line here with a finished shoulder, so a flatter surface as I round around the axial wall, and then I finish straighter across. Obviously, I want them to work in the 3 planes as they're prepping, but what I don't want is any pointy angles here, because that's going to affect the light, and I don't really want any wrap over on the incisal edge. It's going to affect the fit, the passivity, the insertion path, and it's also going to affect the final aesthetics because of the light reflection that we want to create from the incisal edge in veneer world. In full coverage, that's a little bit different. This is more about the coping design. But in veneer world, I want to keep this effect happening. And if this is going to be in full coverage, same thing for my coping design. I want more of a rounder edge here to finish, and then the wraparound for the final ceramic. Okay, in her case, we always want to try to keep a minimal reduction if we can. So let's look at the finalized preparations. And I'm going to show you an overlap of where her teeth were before this. So here's kind of the beauty of it, where we didn't need to take away much tooth structure from the 2-1 or the number 9. Why? Because it was already in a position where we wanted it to be, or I should say the other way around. We took off a little bit more from the 2-1 and a little bit less from the number 8, right? So we didn't need to have as much reduction. We didn't need as much reduction there. We needed a little bit more reduction here. So being able to control that incisal edge position also helps us to control the final preparation and save as much tooth structure as possible. Normal process, I won't spend time with this today, shade taking, communication of where we're going for the final, provisionalization for the patient, and then I'm going to come back and start working on the final veneers for this case. So in this case, we wound up doing 6 veneers on the patient. I'm going to try to create a little bit more translucency, a younger tooth. You'll notice I rounded my teeth a little bit more in the final than they were for the original wax up. I kind of caught that as we were kind of looking through the case. And my clicker's not clicking again. There we go. Okay, so final case, a little bit more of a youthful look. I just wanted to round her teeth a little bit more, give her a little more surface topography, keep that brighter, whiter look going on so you can see the before and the after. A nice case. I think she was very happy and it kind of worked out very well. And again, I always like to see it from this point of view. This is what, we could talk about that incisal edge, but that incisal edge now has this effect where we can actually see the patient. You can see it in their face, you can see it in their eyes, and that's so much more important to me about how I look through it. The other aspect of the incisal edge is managing the air. So in a veneer case, we're utilizing the tooth a lot of times to help us with the support and the light optics. When we're not doing that in full coverage restorations, we're managing what I call the air, the AIR. And that means that there's nothing there, and the light interaction between where your coping ends and where the light is going to pass is much more challenging for you to manage. And in order for you to do that, you're really going to have to manage that space with different materials, like opacious dentin materials, effect chroma materials, even sometimes fluorescent materials, because those are the areas where you're always going to have a more difficult time watching the light management pass through. So as I'm breaking through my tooth, and for those of you who haven't seen this before, I'd like to show it to you from this perspective. I'm always looking at the three planes of the tooth, and I'm thinking about the three areas. My first plane is where I'm usually trying to create the chroma. My second plane is where I'm really trying to create the value or the brightness that you see here. And my third plane, sometimes which is in air, might mean I need some more opacity or maybe not, depending on the effect that I'm looking for, is really about the transition, the age, the effect, the translucency, and the opalescence that I'm trying to create in this area. So it becomes one of the most challenging areas because it's almost easy to create the chroma. It's kind of easy to create the value. But that area is really the area where we struggle to create that. And again, using different materials is what's going to help us to do that and figure out, do I want it to be dentin material here that supports it? Do I want it to be opacious material that supports it? A combination of opacious and dentins? Or do I want it to be more translucent? So I want to have more light going through this area. So I have to really think through that for each case that I work through and make sure I'm making that work. Okay, this is kind of the challenge with monolithic materials, by the way, especially in the anterior. Obviously, with the multi-layer materials, this is getting better. And I don't know if I'm allowed to say this, but there will be some new monolithic materials from VITA in Chicago and IDS this year, and also some new staining materials. So I'm not sure if I'm spilling the beans that I'm not supposed to be, Jim, but I've been playing with some materials. So I get them a little early sometimes so I could play and evaluate them. And a new material called Unique coming out that I was actually taking some pictures of on Sunday, a new staining material, which is kind of cool. And I think that's getting released in Chicago, so I hope I'm right. Point of it is, though, is when I'm working in those monolithic materials, I need to have a material that's going to give me more translucency. So those are coming. And I'm going to need a stain that has a little bit more of effect so I can use that give me more depth and don't hide from the amount of translucency that I'm trying to create. So in monolithic world, I think we'll probably be doing some webinars on that, and I'll be showing some of that more in Chicago. Okay, so let's finish up with a few kind of treatment planning options for my incisal edge position. This is a case that I actually haven't done yet. We're just starting this case. This is a case with Dr. Sava that we're just starting. And she gave me some casts and some pictures on this patient last week. And she said, he's coming in for a consult. I'd like to make sure he understands what we need to do. His chief complaint was that he doesn't show any incisal edge. Typical, right? People see it online. They Google aesthetic teeth, and they say the website says you're supposed to display 2 to 4 millimeters of incisal edge. So they go to the doctor and say, I need 2 to 4 millimeters of incisal edge. So we looked at the patient, and the doctor and I sat down and we went through it and said, okay, how much tooth do we need to give him an incisal edge? So you can see the face, a normal kind of a repose position, his normal smile, and then his big Duchenne smile. We're trying to get him to smile as much as he can. And no matter which one he did, you should notice that the lip dynamic kind of hasn't changed. I mean, he has more bow in the center of the face than anywhere else. And I see the same amount of lower teeth almost all the way through. And I see nothing on the upper. So a simple fix for that would be what? Would make the incisal edge longer. Okay, sounds like a plan, but is that really the case? Because sometimes we have to look at the amount of space we have between the nose and the lip, the age of the patient with the lip dynamics, how much moving they have, and that philtrum column that we talk about, that column between under the nose to the lip, how much um, resiliency and movability that actually has. And that's going to affect what our incisal edge position will be. So we have to kind of work through that. By the way, I have a whole segment on this that I'm not showing today because it's a little off topic, but this will be my part of my Chicago lecture, really going through the facial features, lip dynamics, and all those things. So hope to see some of you in Chicago. A plug for Chicago. You'll notice his teeth are worn, so you should be saying, okay, great, I can kind of lengthen his teeth and make that ideal. It shouldn't be that much of a problem. But I don't know if you caught, notice when he's retracted here, let me blow this up for you. Notice the retracted photo. And if you notice in the retracted photo, notice the upper lip that even retracted, look at how much that upper lip hangs down. Do you really think giving him more length is going to make him show teeth? I'm not so sure, and the doctor wasn't so sure. So we really wanted to kind of make that evaluation before we told him what we couldn't do. So what we did was we, again, after our series of photographs, what I did was said, okay, what's a normal central going to be? Approximately 10 and a half millimeters. Could we push him to 11? Maybe that would help him, but I'm not sure it would. And we wanted to kind of prove out our theory before we got rolling with that. So what we wanted to do was look at the lip dynamic. What is the length of the lip that he has? He actually fell into, I think the doctor felt, and I could be wrong, but I think she felt that he had a longer lip dynamic, that he fell into the longer category. But realistically, he kind of fell around the average point. So it really wasn't the length of his lip that was the issue. It was more about the dynamic of his lip that was the issue. He didn't have very much mobility or dynamic in the lip. By the way, you see this much more with women today because of all the enhancements that they're doing with injections, right? So some Ritalin and some fillers in the lip. So because of this, you're seeing much less lip dynamic, which means now they're trying to get longer incisal edge positions, which doesn't always work very well. So in his case, we actually went back and the doctor did a great job kind of trying to measure, and he falls somewhat into the normal range. Maybe it's a slight bit towards the long, but the bottom line is I don't really think it's the length of his lip. I think it's the mobility and the positioning of his lip. So took our digital cast. Here's a perfect great time for digital models. And I said, okay, let me make a 10.5 millimeter, 11 millimeter central. So I added some wax to the teeth. This is what we call a dirty wax up, really quick, not really paying much attention to it. I'm just trying to get to the length. And we were about 10.5 to 11 millimeters here. And we're going to take that and we're going to insert that into the patient's mouth and evaluate if it works. Now, if you look at it from this perception, or this perspective, I should say, that's almost an 11 millimeter central. Can he tolerate 11 millimeter central? I think functionally and aesthetically he can. So, okay, now we know that we can give him teeth that we want him to have. The challenge now is, will his lip dynamic allow us to do that? Again, this will be part of the Chicago concept. He doesn't really have much of a lip bow in his philtrum column. He kind of has more of a straight across. What he really has is a reverse bow. He actually has where the lip kind of drops down more. So no matter how much we give him, he's really not going to show that much tooth. And he has to know that ahead of time going in. It almost looks like my wax up is pulling up. Maybe it is a hair, but realistically it's because the drop of the lip more on the patient's left side. So he's not going to get the incisal edge display that we'd like him to have. And because of that, he bought into the case. It will be a full mouth rehab, but at least it has set the parameters for us to know what the end result will be. We'll try to balance that by getting that little extra 0.5 out of the incisal edge, but we want to make sure that we're not creating this huge kind of Bugs Bunny look on him as we work through the process in the case. So this case will be starting, and maybe I don't think it'll be done. It won't be done for Chicago for sure. This will probably be another 3-4 month process, but it's going to be a nice case. So you guys will probably see it more towards the end of the year. All right, last case I'll finish with on time just to kind of go through it. And I kind of just popped this case in really quick. This is not my photos, but the reason I put it in was because I wanted to show you that it's all the work we do to get the incisal edge in the right position and create the right effect for the patient. I sometimes miss it too. And actually, this is a case that I think we all kind of missed something here a little bit, and I'll explain to you what I mean. So this is Barbara. Barbara works in one of my offices here on the island, and she's a sweetheart of a lady. She's been in dentistry for 30 years already. She started when she was 12, so that's why 30 years. Um, and Barbara was really unhappy with her teeth, and she's kind of at a point where she's semi-retired. She's like, I've been taking care of people's teeth their whole life, and I think I want to have my teeth done. So she didn't really want to have any crown lengthened. She didn't really want to do anything crazy. She just wanted some prettier teeth, as she kind of said. So we started with the upper arch, and we went through the sequence of what we wanted to do and how we wanted to treat it. But I do want you to notice in her face that even though her teeth look a little old and a little discolored, they kind of work in her face. That incisal edge position works. They kind of work, and even the rotations kind of work a little bit in her face. So this is where we started. I went and did a normal diagnostic wax ups. We made her a provisional. And that provisional, this is a little old, so it's yellowing out on us already, but you can see the provisional kind of works, but it didn't really work for me. It kind of felt like some things just didn't look right with it. But I think we missed it at this point because I actually went forward. I made the final veneers. I made them kind of bright and white, a little narrower. I tried to make them fancy. And this is Barbara taking a look at the veneers that I made her in the chair with a mirror, and watch kind of her reaction.
Oh, wow. Wow. They look like real nice teeth.
So what's funny about that comment is she didn't say they look great. She didn't say, oh boy, I'm so happy. She was a little taken back. She said they look like really nice teeth. But you could hear that hesitation in her face where she almost felt a little bit like she didn't know if she liked it or not. So she went home with those teeth. She wore them for a month or two. And then she kind of sheepishly came into the office one day and said to the doctor, I don't know. I don't like them. I'm not happy with them. And the doctor said, well, what don't you like? And then she sent me a picture, and I looked at it and I'm like, oh, yeah, I kind of get it. It's a little too much tooth for her. It's maybe a little too bright, maybe not enough translucency. Maybe there are just things that didn't work. And I get it. We made a mistake. So no problem. Let's get them out. Let's redo them. And let's do the right thing. And Barbara was fine with that, and the doctor was fine with that. So we took them out. We prepared the teeth a little bit, and I came back and warmed the teeth up a little bit, gave her a little flatter tooth, a little bit more surface topography, and gave her something that fit a little bit more in her face. And I think the point I wanted to make is as much time as we spend trying to make everything ideal, you got to remember that those effects you're putting in, that final shape, that final surface, the final translucency, mamelon material, all the things that you're doing, they have to work in the face unless it's conformative dentistry. Unless it's a single central or two teeth, you have to follow what's there. But when you get into these larger cases, the face is what will rule in these final cases. And Barbara was a great example, and she was great with it. She understood that we were going for more than maybe we should have, and we wound up bringing her back and finalizing her case. So you can see that we've shortened her incisal edge a little bit, that we've added a little bit more color and a little more of a squarer tooth for her, and it just fit and worked better in her face. And now she's over the top happy. I don't have the new video of her with a different excitement yet, although I will, because we actually just inserted these a few weeks ago. But yeah, comes along, and Barbara's happier, and this is on the insertion date, so the papilla will still be filling in. And now we're going to address the lower teeth in here in the final. So point was, incisal edge, she's got a little effect, she's got a little transparency, a little color and warmth going through there, as compared to what I did the first time and gave her too youthful of a tooth, a little too long, a little too much brightness to it. So make sure you make those teeth really fit the person that you're working on and not the other way around. And here's Barbara's final. I'm really, for me, I always get antsy because I can't wait to see this papilla come in and everything kind of finalized. It'll look so much better as we go on, but there's her final on insertion day. And there we are. So I think I'm right on my time here. Is again, ooh, look at that, 50 minutes. See, perfection. The first one of the year. We nailed our time. I'll say thank you from here. And if you guys have any questions, you can pop in. Thank you for joining. Looking forward to seeing you in Chicago and Canada and Cali the next few weeks. And hopefully there's some questions out there. Thank you, Jim, for kind of revisiting this title a little bit. And I hope I kind of added to where we had started from.
No, I liked it. It was expanded on what we did talk about a couple years ago and last year. So fantastic. So appreciate it. Before we get on to the question and answer portion, CE, those of you that have typed in asking about CE, you'll get it. Give us a couple days to process those. The webinar has been recorded, so visit us on our website, VITA North America YouTube channel, where you'll see this one plus other webinars that Peter actually spoke about during this program as well. So we've got, at this point, several hundred videos of webinars and so forth. If you need to have your access to a rep in your area, here's a list of all the reps and so forth that you can access and contact. This, of course, will be included in that webinar, so please visit that, call them up, get a hold of them. We have other programs the rest of this year. Peter is going to do several more this year. We have a Germany workshop that if you're interested, you can sign up and join us in VITA Zahn Fabric in Germany in May-June time area. We also have, Peter mentioned it, Chicago LMT coming up next month. And then we have a bunch of other webinars coming online as well. So we try to do 2-3 webinars every month. And those are all recorded and placed on that VITA North America YouTube channel. So as far as question and answer, let's look at the questions here. The envelope of function, the incisal length, what's the priority? The length, for the smile, the removal of interferences, the overjet, overbite?
Yeah, so it's kind of it's D, all of the above. You want to incorporate all of those things. Would I sacrifice the aesthetic parameter, which is the incisal edge position, for a functional parameter? And the answer is no. The aesthetic parameter dictates where I want the incisal edge to be. The functional parameter may limit that. So what do we do to address that? There's several ways to do that. One, once we decide the incisal edge position, we have to consider the rest of the case. What do I mean by that? Do I need to orthodontically move the lower incisors? That could be an appliance, an instrument aligner, or something along those lines. Do I have to open the vertical to create more room for the envelope? Or are there limitations where I'm just restoring 2-4 teeth and I'm limited by the lower functionality? That's going to limit my incisal edge position.
All right. And those of you that are on, please send any questions you have. And just a note, Peter's gracious enough to let us provide you with his contact information. Peter is a very busy individual. He travels a lot, does a lot of lecturing, teaches at the school, New York University and so forth, NYU. So give him some time to get back to you if he doesn't get back right away. Another question is, beyond the photographs, do you ever have the dentist provide you with video of the patient?
Yes, it's a great question. I do. We love video. We use a lot more of it today. I don't always show them in the webinars as much as real cases, only because playing videos in the webinars, I find sometimes it's hard to control the volumes and everything. But yes, we use a lot of them. I think video is fabulous. Those of you who have watched all the photography webinars, you probably know that I'm very critical about the type of camera you use and all the things that go into the lighting and so forth. But when it comes to video, I'm okay with your iPhone. I'm okay with, because those are really just about lip dynamic movements. And it's really nice to capture that patient in their true environment. So what we ask the doctors to do is, if you're filming your patient, as you're filming them, you kind of make it more casual. Just have the camera going, start asking questions, and then getting into a routine, meaning that getting them talking and going. That's where you'll get the most realistic approach of their lip dynamics and the ability of what they can do. When you try to take that picture, a lot of times they're frozen and they don't give you the same dynamic. So video is fabulous.
All right. As far as communication go, you have your system where you are very close to your dentist in communication and providing back and forth. But a lot of laboratories, how do you recommend most labs really communicate with their dentists on treatment planning, on how to design their the framework or design the case and so forth?
Yeah, so let me kind of address the way you said that the question. This question was worded just to make sure. So first off, I'm a small lab. I work with about 15, 18 doctors, kind of, U.S. and even international, a few. I only have 3 local doctors that I work with, in truth, and I'm lucky enough that I do see a lot of those patients. But all my other doctors is more about the communication processes back to photographs and videos. I do meet with some patients via Zoom, so we do have the ability to do that today, where I can show them what I would show them when they're here about what the tooth looks like and the chroma and the value. But here's where it's kind of interesting. My local doctors probably used to send patients here all day long. I probably see 3 patients a day, 5 days a week. I don't see as many patients as I used to because they've gotten so good with their photography and their communication that the truth of it is, the only time I'm really meeting the patients these days again is when the doctor wants me to kind of go through their aesthetic parameters. And I don't want to say seldom the case because that sounds like a cheap way of doing it. But I think what happens is the patient appreciates our point of view from a technician because we're the artist part behind the scenes, whereas the doctor, we call it the hitman, right? They're always telling them what they need and how many teeth they have to buy and all that. So I think I meet patients more because they're either really concerned about what they want and they want to kind of work closer with us, or because we want to show them what we see from an artistic point of view. But we're doing those same diagnostic evaluations. I'm doing that almost with all my doctors today. And I think, as Jim said, as busy as I am traveling and teaching, I spend so much time on the phone going through cases. It makes it so hard to catch up on my building because I'm still building all my cases. So yeah, it's a challenge, but that's the way we do it. We work close with the photography, and they've all gotten so good with their photography and their communication today. So that's our treatment plan.
All right. Now the question is, when creating bridges on implants or on natural teeth, how do you manage the space during the buildup process to achieve an aesthetic result? So that might be proportions, maybe. How do you, your golden rules of, space of width and length and embrasures and things like that. I think it's
I'm
everything.
not sure if that meant or they meant that when you're building an implant versus a natural tooth, let's say we have an 8 and 9, the facial of a tooth is in a certain position. The implant, there is nothing, right? It's like all air. So how we manage that space, I think that's where they were going. If I'm wrong, they can correct us. But I think what they're asking is how do we manage that space because it's way more difficult, and it is. We have the misnomer in our profession that ceramic should, we want the minimal amount of space we can to work in, or we need more space to work in, I should say. And I would argue it's not true. Our ceramic is built to work in about 1.5. So if I'm working on an implant next to a real tooth, I have 3 millimeters of space that I have to manage. I have to manage that with my substructure material choice, meaning how much opacity or value do I need, and then my layering process. As an example, implant number 8, crown number 9. I'm building that number 8 to get out to the same position as the final coping in my number 9, usually with more opacified materials, maybe more fluorescent materials, to create similar working canvases before I start my dentins and enamel buildup. So if that's what you were going for in the question, I think it was, that's the way I would usually manage it. It's really material selection and managing capacity from the internal aspects of it.
Yeah, I think you fairly covered that. So thanks for your interpretation of that. Sometimes I misread into things. So
you might have got it right, but I was thinking that's what we're kind of going towards.
Yeah, that's great. All right. So another question is, as you layer a anterior and incisal, 8, 9 doesn't matter. If you start your translucency on the distal or mesial line angle on the opposite contact point in line angle, say if you start sculpturing your layering and you put some of your enamels along the line angles of your distal and you bring it down to a certain point, do you do the same thing to the opposite side at this end at the same point, or do you vary that to be a little bit different? Is what
Yeah,
I
so a few things there. And again, I'm not sure if it's your wording or someone else's. A line angle to me is usually not translucent. It's more of an opacified or a brighter material to accent the line angles. The translucency is more the circumference of the tooth. And I think the answer I would give to the main part of the question is two centrals, two laterals. They're in the same family, but they're not identical twins. So no, I don't want it to be exact. I want it to be similar because that's in nature. I don't want one to have 4 millimeters of translucence and the other one to have one. That would kind of look silly too. But I'm not looking to make them exactly the same. I'm just kind of getting in a close ballpark. The only thing I ever really care about being the same, and I always kind of address this in courses, is when I'm working on an 8 and 9 or the ones, I want those mesial heights of contours and the mesial basically contour itself to be almost identical. After that, the further I go towards the distal, I'm not looking for identical twins anymore. I'm looking to match the dominant and non-dominant sides of the face.
Okay. Um, so we kind of get this question in a lot talking about because everyone's looking for a monolithic, right? Zirconia, zirconia, zirconia. The question in general is, what ceramics is widely used? What if you had to pick one, which you can, in one material? Would you do all ceramics? Would you do zirconia? Would you do PFMs? Would you do?
I can't pick one. I'm sorry. I always answer honestly, and I'm answering honestly now. There isn't
No,
one. I think ceramics is key, and I think I would argue that a lot of the labs that are so focused on the monolithic world. Don't get me wrong, the monolithic world has gotten great. I just finished a case yesterday that I'll probably show in Chicago, where I did a monolithic crown. It was a 2-unit case, a cantilever cuspid. So the cuspid was minimally prepped, and then I had a cantilever in the lateral. I did it in zirconia. I did the cuspid monolithic and the lateral fully layered. And I did it on purpose. I wanted to make those two match. And I think I did a pretty good job matching them. So I'll show you that my choice of zirconia and how I stained and blah, blah, blah. Actually, that was with the new unique material, which I'm not allowed. I don't know if I'm allowed to say or not, Jim. But
you say
I did that yet a Sunday when I was here taking pictures of it because I wanted to show that in Chicago. In an ideal world, I think the only thing that I feel like is a little mistake-ish for us is to only be focused on one version. Monolithic is great, layered is great, machinery and CAD is great, printing is great. But your value is not only doing the cheeseburger. Your value is being able to address the need of every specific case. That's what keeps your lab busy and growing, not how fast, not how cheap. I've said it 1,000 times. So the ultimate restoration is what's best for that particular patient at that particular time in that particular space. And that might be a thimble metal coping at 0.2 of a millimeter with a ceramic margin. It might be a monolithic zirconia. It really depends on all the effects that I'm looking to achieve in that moment.
all right. Well, let's wrap it up with this last question. What do you use to polish the final restoration? Pumice grit mixed with aluminous oxide.
So yes to that. I used to do that more. I got to be honest, I've been a little on the lazier side lately, and I've just been using rubber wheels and diamond pastes. And I have I have like a leather brush wheel that I use to do a little surface on. But I have to be honest, I've been a little lazy and I haven't been kind of going in the back and pumice polishing as much as I used to. I kind of want to get back to that a little bit. I've been really working on some texture and topographies and things and my surface. But what I did do that might help you is I'm kind of trying to break away from some of the glazed pastes. If you're doing monolithic and you have stains, you have no choice but to use glazed paste. I get it. If you're layering, you don't have to use the glazed paste or as much glazed paste. That's kind of become a crux for us. We're all painting glazed paste on and moving on. That's what you don't want to do. So if I use a glazed paste, I'm mixing it sometimes with what's the material? I forget the name of it. It's a VITA material, finishing agent, right? I might mix that with a little bit of finishing agent, and then when I'm done glazing it, I break it with a rubber wheel and then come back and polish with diamond paste. Or you can use a regular denture polish. But in the end, I think what's hurting us most from the final topography is if you're layering and you're still just using glaze pastes, you're kind of defeating the purpose of your surface texture and final luster.
Great, thanks. And for those of you have joined us, there are Peter actually did a webinar last year on topography, so you may want to visit that on the VITA North America YouTube channel. And then Peter, any last words? I want to thank you very much, of course, for answering all the questions, going through the presentation. You did the content was excellent. I always learn things. So, any parting words for the audience?
Welcome to 2025. It's good to see your face. I'll see you in Cali, I guess, in a little bit, or in Chicago next month. Looking forward to seeing you guys. Like I said, I'll be in Toronto for a course. I'll be in Cali. I'll be in Chicago. So I really look forward to everybody. My heart goes out for everybody in Cali. If we could do anything that's helpful, don't hesitate. If we can mill something for you or something you need to help get your feet back up on the ground, you can reach out and we'll try to chip in any way we can. Hopefully everybody gets back on the feet as quick as possible, and sorry for all the stuff that we've lost. And as long as you're alive is really what matters, hopefully. So look forward to seeing my friends around the country, and thank you guys for tuning in for another webinar of 2025, and see you next month. Same bad channel, same bad time.
There you go. And then Peter's information is on the screen. So if you do need to contact him with additional questions and so forth, or any follow-up, feel free to give him a ring, a jingle, an email, and then he'll get back to you as soon as possible. I want to thank you again, Peter, for doing these. You're very great. You're great at taking the topics and running with them and interpreting them and providing excellent education as always.
Up good topics, so it makes it fun and challenging. Thank you.
Well, we'll continue that with 2025, as you mentioned. I want to thank everyone that attended today. Again, you can visit the VITA North America YouTube channel to see a follow-up video of this webinar. Otherwise, everyone have a great day wherever you may be, and we will end this webinar as of now. Thank you for attending.